We are going live in 3, 2, 1. We are live now.
Sure. Arun, let me know when I need to begin.
Definitely, sir. Just give me 2 minutes.
So,
Actually, there is some problem.
Marti Kapran, Sauti Shukranazi.
Hello.
Sauti
Dr. Sudhir Shasha has joined.
Good evening.
Yeah.
Sir, we are live now, Dr. Shah.
Live? Okay, fine. Yeah, sure. Go ahead.
Arun, shall we?
Sir, 1 minute.
So Sudhir sir has joined.
Yes.
Thank you very much. Thank you.
Sir, you can start.
Thank you very much. Okay.
Sudhir sir, mute please. I'll just introduce you.
Yeah,
Sure.
sure. This is 58.
56. I'm just introducing you, sir. Okay. Good evening, ladies and gentlemen. A warm welcome to Secrets of Neurology. It's a knowledge feast for all neurologists. And this time we have another prestigious institute, King George Medical University, Lucknow. And the title is equally interesting, Lost in the Labyrinth of Mind, Neurological Odyssey of Altered Sensorium. We assure you that it's going to be pretty exciting. It's going to be a feast, which is going to continue for 1.5 hours. All this has been achieved. This 56th episode has been achieved because of support, guidance, mentorship, coaching of two of our program directors, Professor Dr. Sudhir Shasa, Professor in HOD at prestigious SMT, NHL, MMC, and SBPI MSR, Ahmedabad. And sir is also Director of Neuroscience at Sterling Hospital, Ahmedabad. Many accolades to his credit, but he always guides me to keep it brief. Conferred with Padam Shri, Bharat Gaurav Award, at Senate of France on 5th June 2024, one of the highest international award for Indians. Sir is also recipient of prestigious Dr. B.C. Roy Award. Dr. Suresh Asar's interest is into stroke, neurodegenerative disease, and epilepsy. Thank you for your continued guidance, sir. Professor Dr. Lakshmi Narasimhan Ranganathan, sir, we know him equally well. Director and Professor of Department of Neurology at Sri Ramchandra Institute of Higher Education and Research, Chennai. Excellent mentor, coach, and contributor in the field of neurology. Recipient of Paltussi Advisor Award, A.B. Bakers Award, Best Paper Award by AN. He's been the 3-term executive member in Indian Academy of Neurology. He has been guiding and mentoring DM and DNB students across India. May I request both our program directors to take it forward from here. And ladies and gentlemen, we are inching very close towards the 5th year. Over to you, sir.
Thank you, Dr. Manoj, for this kind words of introduction. It gives us immense pleasure, joy, and satisfaction that we are touching now 56th episodes, a continuous series of updating knowledge for all neurologists, especially for the students of DM and DNB. Somehow it has been very popular amongst the teachers and practicing neurologists also. So thank you for all participation from the different corners of India and abroad. Thanks to all the delegates for continuous support and encouragement. And my special thanks to my colleague, my course director colleague, Dr. Lakshmi Narasimhan, for his terrific efforts to uh, find the different institutes. And I'm also thankful to all the different big institutes of India who have participated relentlessly all throughout this fifth year for case presentation followed by discussion and localization with expert comments from the chief. So all the residents have done extremely well. All these episodes are archived, and I'm told that all students who appear for DMDNB, they frequently try to uh, go through these episodes and take several important pearls from this. My thanks to special thanks to Mr. Arun Chadda and his team at INTAS Global Cell Division, that is Celestial Division, and the network and infrastructure they have provided is of immense value for this continuing series. And I would like to mention today's. May I have the first slide, please? Yeah. Today we have KGMC, that is King George Medical University, Lucknow, who is the institute who is presenting Secrets of Neurology today. The case presentation will be done by Dr. Shailesh Kumar Thakur, Senior Resident, Department of Neurology. May I have the next slide, please? And the next one. Dr. Swanshu Batra, the Assistant Professor of Department of Neurology at KGMC, who is DNB Neurology, MRCP Neurology at Royal College of Physicians, and Doctorate of Medicine in Neurology at Sanjay Gandhi PGMS. She is recipient of first prize of national level quiz of movement disorders recently, last year in MDS ICON, recipient of third prize for quiz of national movement disorder in 2022, and second runners-up of the other All India postgraduate rheumatology quiz. And she has interest in sleep medicine, neuroimmunology, neuro rehab, and so on. Next slide, please. My friend Dr. Hardeep Singh Malhotra was very kind enough to accept this invitation at a very short notice when we met recently at Varanasi. He's a professor, Department of Neurology at KGMC, and is Dean Research KGMU and co-director Cochrane India Network, KGMU affiliate. He is got Vice Chancellor's Appreciation Award in 2024, Eminence Research Award in 2019, Professor Devendra Kumar, Young Investigator Gold Medal in 2014, and another gold medal in 2003. He has more than 225 publications. His special interest, everybody knows that he's quite deep into tropical neurology and movement disorders and systemic review and meta-analysis methods. That's why he's with the Cochrane. Now the head of department, Dr. Rajesh Sharma, our multifaceted personality, we know him as a singer and dancer. Also, he is also from the same institute. He has more than 356 publications in index journals. He is FIAN, he is FAN, Fellow of American Academy of Neurology. He is listed in top 2 scientists of the world, rated by Stanford, and listed in top 15 authors of the world in CNS tuberculosis. His special area of interest is again tropical neurology, dengue neurology, neuroinfection, tuberculosis, meningitis, Guillain-Barré syndrome, stroke, and others. So, friends, uh, me and my colleague Dr. Lakshmi welcome you all for this knowledge feast, and we thank the parent institution KGMC, headed by Neurology Department Dr. Rajesh Verma and Dr. Malhotra, who would be taking this forward. Thank you very much, and over to Dr. Verma, please.
So before Dr. Verma, just 1 minute, sir. Another new facet of Dr. Rajesh Sharma, which I came to know, that he is an MBA in artificial intelligence.
Oh, that's great.
He is qualified from the DY Patil. He's
My
recently
God.
done in artificial intelligence, and I was interacting with him. I never knew that he was so much into technology. The another important fact of Professor Hardeep was he was the Cochrane, one of the very founder member of the Cochrane Indian South Asian Cochrane network. Sir. He was there for along with Sridharan, and so these two I was so impressed. Two giants of the field. I'm very happy that they are here. Over to Professor Rajesh Verma.
And the topic also they have mentioned is very peculiar.
It kindles so much of interest into all of us.
So
Thank you.
it's a kind of odyssey that we have to now unfold and see what exactly. All right, welcome. Thank you, Dr. Lakshmi, for heading up.
Thank you, sir. Thank you.
Professor. Malhotra, sir.
So I would request Dr. Saritesh to start the session. So he would be detailing on the case, how it presented, how things moved ahead, and it would be dissected in terms of the anatomical substrates and things which are related or important with respect to the differential diagnosis by Dr. Swanshu Batra. I'll try to add few of our important observations in the past few years, say a couple of decades. And this is how I'll move. I'll request Dr. Saritesh Thakur, our Chief Resident at the Department of Neurology, to start. Dr. Saritesh, please.
I've started sharing the screen. Is my screen visible?
Yes.
Good evening, sir. Respected directors, faculty members, and my dear colleagues. I thank everyone to provide me the opportunity to present the case in the Secrets of Neurology. Let me begin the 56th episode, Lost in the Labyrinth of Mind, a neurological odyssey of the altered sensorium. Coming on to the history, the patient was a 52-year-old male residing at Farendra Jagir, Basti in Uttar Pradesh, who is a teacher by occupation, a double postgraduate, right-handed, and with a pre-morbid condition wherein the patient followed a very well-structured daily routine, woke up at 6 a.m. daily and completed his morning rituals, worked from 9 a.m. to 5 p.m. with a job where his role was training government school teachers and leading a state-level education department. After work, he spent time with his family members and socialized with friends and relatives. And he went to bed around 10 p.m. He presented to us with chief complaint of altered sensorium for last 30 days. The story starts with our team being called to attend a middle-aged patient who had presented with the complaints of altered sensorium for the last 4 weeks. In the first week, the patient was grossly confused and had irrelevant talking and had a history of irrelevant talking. And by the second week, he had become more lethargic but still he was responsive to name calling. By the third week, he stopped recognizing his relatives and he stopped communicating about his daily needs and was arousable only by a painful stimulus. And by the fourth week, he was not arousable by any stimulus whatsoever. Coming on to the examination, we found that the blood pressure of the patient was 144/70 and the pulse rate was a bit increased, that was 124 per minute. His temperature was normal. The systemic examination of the other systems was also grossly normal. Coming on to the neurological examination, as we can see in the video, the patient's GCS was around E2, V2, M5 and he was stuporous. Bilateral pupils were 3 mm and reacting to light. And there was roving eye movements, which we'll see in the next video. All his 4 limbs, as we can see, are fixed in the flexed position with rigidity that is both axial and appendicular. All the while he was moving all the 4 limbs to deep painful stimulus. Reflexes, specifically the deep tendon reflexes, were exaggerated in bilateral biceps, supinator, triceps, knee and ankle. Left ankle also showed inducible sustained clonus with a plantar reflex that was bilaterally flexor. As we can see in this video, the patient had a roving kind of an eye movement in both the eyes. So when we saw a patient like this, we probed further into his history and we found that the disease actually started about 2.5 months ago in January. His chief complaint at the time was blurred vision, and his self-estimated clarity of vision was reduced to just 30 to 40% of what was normal. This blurred vision was episodic and was reversible with complete recovery in between 2 episodes. These activities of daily living were unaffected between the episodes, and he consulted multiple ophthalmologists all across the state of Uttar Pradesh, and all their examination reported normal findings. The patient was then shifted from Uttar Pradesh to Surat, where his son was working, because they were not satisfied with whatever ophthalmological evaluation was being done here. The patient, once he reached Surat, started to have cognitive symptoms in the form of memory disturbances, like the patient started to misplace objects, started to forget where he had placed the objects at certain times. He had some behavioral abnormalities, which we'll be discussing in detail later. He had abnormal body movements of either left or right side of the body with neck deviation, without loss of consciousness, bowel bladder involvement, or frothing from mouth. After about 1 month into his illness, he was admitted in Hospital A under a psychiatrist on 7th of February 2025 with the complaints of behavioral changes, which included irritability, anger, stubbornness, excessive talkativeness, sleep duration reduced to less than 2 hours, with episodes of recurrent inspiratory stridor. These were also associated with emotional symptoms like unprovoked laughing and crying. And there was also functional decline in the form that he stopped working and he immersed himself in religious activities like chanting Hanuman Chalisa again and again throughout the day. The patient also developed an intense fear of animals and a belief that someone from his village has placed a curse on him. And that was and as a result, he had been facing all these problems. His diagnosis was made as mania with psychotic symptoms by the psychiatrist, and he started him on injectable as well as oral medications, with injectable being haloperidol and promethazine, and oral medications including lithium, clozapine, valproate, lorazepam, indapamide for some duration due to hypertension, amisulpiride, and hyoscine hydrobromide. As a result of all this treatment, there was some partial improvement in the patient, as in his anger and irritability reduced, but the other symptoms persisted. The patient was then sent home. As we already saw, his anger had reduced, but delusions persisted along with his stubborn behavior. New symptoms developed, as in he started to see Hindu goddesses while performing puja and also propagated his wife to pursue the same spiritual path. He would also berate his wife occasionally for trivial things like lying down on her bed while he was praying to the deity, who according to him was already sitting on the bed. He was very stubborn about visiting a temple because for him that was the only way to overcome the curse placed on him. After some days, while he was, the entire family was going to visit a temple, his relatives noted that he had difficulty in walking on uneven surface and required support to prevent himself from falling. This prompted the family members to seek a different opinion, and they would now shift the patient to a hospital B on 28th of February, and that was the first time he encountered a neurologist. During this period, his daughter-in-law was the chief attendant, and she complained that during the hospital stay, the disease has progressed further, as in she failed to recognize her at times, and he started having visions of animals like cat, which were going to pounce on him. This led to a feeling of extreme fear and agitation, and hence the attempts to flee from the situation. All these episodes were also associated with systemic symptoms like profound sweating, hypertensive episodes, and tachycardia. It was during this hospital stay that we also recorded the first and the only episode of fever that was of 102 degree Fahrenheit. All these things were also associated with decreased food intake. The management at hospital B was taken forward, and they stopped all the antipsychotics and sedatives and started the patient on steroid in the form of methylprednisolone, 1 gram intravenously for 3 days. Since there was no improvement in the patient and his condition kept deteriorating, he was shifted to a different hospital C on 2nd of March of this year only. On arrival at hospital C, the patient condition further worsened and he became stuporous. Here, the doctor started him on IV antibiotics and anti-epileptic drugs like brivaracetam, and they continued the methylprednisolone for another 2 days. As per the record, it was the first time that we saw that there were instances of fluctuation in blood pressure and heart rate. As we can see on the chart that is described here, both pulse rate and heart rate had frequent fluctuations all during the day. As a part of management, they also restarted the antipsychotics in the form of quetiapine and endoxifen. Now, the patient was not improving, and they were far away from their home in Uttar Pradesh, and so the family members considered to shift him back to Uttar Pradesh, and the patient was moved to a private hospital D in Lucknow under the care of a neurosurgeon. Here, his condition worsened, and his GCS dropped, and the patient was intubated. The clinical findings included fluctuating blood pressure and tachycardia, deteriorating neurological status. The neurosurgeon here suspected him of having hepatic encephalopathy, and he started the treatment with supportive measures like intubation, mannitol, and glycerol. The patient was given steroid in the form of methylprednisolone, 1 gram for 3 days. The patient was started on antibiotic and hepatic support in the form of rifaximin and L-ornithine L-aspartate. Cerebroprotective agents like cerebrolysine were given. Anti-epileptic drugs in the form of levetiracetam were given. Antipsychotics included thioridazine, and antihypertensive included clonidipine and carvedilol. The patient then came to our hospital, and to carry on our today's presentation further, I would like to hand over the presentation to the next speaker, Dr. Swanshu Batra, who is my senior and assistant professor in our department. Thank you.
Please unmute
Are
yourself.
my slides visible?
Yeah, they're visible. Yeah, please.
Yeah. Good evening, everyone. So I will carry forward the next part of the presentation, and that is diagnosis, management, and clinical course of this patient. So the story starts with a 52-year-old male who had presented with subacute onset of rapidly progressive decline consisting of intermittent visual disturbances experienced over the past 2.5 months. 1 month into the illness, he started having symptoms of cognitive decline in the form of alterations in behavior and personality, along with recent memory difficulties. About a week later into the illness, he started complaining of abnormal body movements and sleep issues. And the relatives give a typical history that he used to sleep just for 2 hours in the day, along with inspiratory stridors, as soon as he started to sleep. Following this, 1 week more into the illness, he started complaining of gait difficulties accompanied by propensity to fall for the last 5 weeks almost, which was followed by the current chief complaint of the patient, that is altered mental status with visual hallucinations observed for the past 4 weeks. And this was noticed, the dysautonomia, the next complaint was noticed by the treating physician over the last 2 weeks of hospital stay. So, to summarize, we have a case
Swanshu,
that...
sorry to interrupt. Can you please remove the pop-up from the window? I suppose there is a pop-up on the main screen.
Just a minute. Are my slides visible?
No, no.
I'll just share it once again. Now are they visible?
Yeah, they're visible. Now try to go to the full screen mode.
I am really sorry for this technical thing. Now is it okay?
Yeah, it's fine now.
Yeah, thank you. So to summarize, a 52-year-old male had presented with subacute onset rapidly progressive course consisting of intermittent visual disturbances experienced over the past 2.5 months, followed by cognitive decline in the form of alterations in behavior and personality, along with recent memory difficulties for the last 1.5 months, abnormal body movements and sleep issues for 1.5 months, followed by gait difficulties accompanied by propensity to fall for 5 weeks, and which was later followed by the current presenting complaint of patient, that is altered mental status with visual hallucinations observed for the last 4 weeks, and dysautonomia noted by the treating physicians during the past 2 weeks. So, coming to the anatomical substrates of patient's presentation, intermittent visual disturbance suggestive of some pathology localized to the occipital cortex. Behavior and personality changes localized to dorsolateral prefrontal cortex, medial temporal lobes, and the limbic system. Abnormal body movements. We could not ascertain in detail what kind of abnormal body movements they were, It could be myoclonus or focal seizures, with its localization being cortex or subcortex. There were profound sleep disturbances which we localized to hypothalamus and its connections. Gait difficulties, we could not ascertain much from the history given by the wife, but we kept the possibility of pyramidal or extrapyramidal or cerebellar involvement in this patient from the history. Altered mental status suggested involvement of reticular activating system and its connection with thalamus and cerebral cortex. Dysautonomia indicates involvement of hypothalamus or insular cortex or brainstem. Coming to the anatomical substrates of cognition, anger, irritability, and stubbornness localized to dorsolateral prefrontal cortex and mesolimbic pathways, inappropriate laughing and crying localized to orbitofrontal cortex and mesolimbic pathway connections, complex form visual hallucinations localized to the disorders concerning ventral stream, that is occipitotemporal connections, intense fear accompanied by sweating, that is our our fear in response to the visual stimuli. There is a very beautiful paper published in 2015 where they have shown functional MRI correlates of fear accompanied by visual stimuli. They suggest that there is activation of the occipital cortex via the lateral geniculate body, and then through the ventral stream there is arousal of amygdala, and there are three other pathways concerned with it, with the connections of the ventral stream to the orbitofrontal cortex or parietal cortex or prefrontal cortex. Any of these four pathways may be involved in this kind of a presentation. Persecutory delusions, that he has been cursed by someone and that is the reason for his deterioration in health, that is localized to dorsolateral prefrontal cortex, left orbitofrontal cortex, and hippocampus. Though this localization is very poor and not very strongly established by the fMRI studies. Hyperreligiosity is also a poorly localized symptom, but it has been observed that hyperreligiosity is a feature of obsessive compulsive disorder, schizophrenia, mania, and temporal lobe epilepsy. Hyperreligiosity in these four disorders give us some idea that hyperreligiosity may be linked to frontal lobes, temporal lobes, and limbic system. The recent memory loss suggests involvement of the structures of Pepys circuit consisting of hippocampus, mammillary bodies, anterior thalamic nuclei, cingulate gyrus, parahippocampal gyrus, and entorhinal cortex. So, localization summary involved the involvement of cortex, occipital, frontal, and temporal lobes mainly, along with pyramidal tracts, and subcortical localization composing of limbic system as well as the extrapyramidal system. And we were very much into keeping brainstem also as our localization because of the profound sleep disturbances that the patient had, the inspiratory stridor at the onset of sleep that the patient complained, as well as the involvement of the reticular activating system and the worsening of the sensorium, along with autonomic instability, which could have been attributed to the brainstem involvement apart from insula and the hypothalamic involvement. So with these diffuse localization of cortex as well as subcortical regions in mind, there were some questions that were yet unanswered by my resident in the rounds, and therefore we reviewed the history. As previously he was diagnosed as hepatic encephalopathy by hospital D, I had asked him, was there any history of jaundice? He said yes. Before 6 months, there was history of jaundice that had lasted for 1 to 2 months. To ask for signs of chronic liver disease, I had asked for history of hematemesis, abdominal distension, and bleeding from stools, which was absent. To rule out measles as a cause of this presentation, I asked for the history of measles. There was no measles in this patient. There was no history of long-standing fever or joint pains or skin rashes or photosensitivity or orogenital ulcers. There was also no history of urine becoming dark on exposure to light. There was no history of headache or migraine with aura in the past. There was no history of cough or chest pain or abdominal pain. There was a history of surgery. He had underwent a laparoscopic inguinal hernia repair before 15 years. There was no history of blood transfusion. And there was also no history of exposure to animals or dealing with medical instruments. So I dig in more into his personal history. I asked for the history of any substance abuse or high-risk behavior. Saritesh said no. We also inquired for the history of recent travel, and we did not get that. There was a history of significant weight loss and anorexia for the past 1 month, and there was a weight loss of 5 kg in last 1 month. The dietary preference of the patient was vegetarian, and the family history in this case was not significant. So whenever such a case comes to our mind, there are a myriad of differential diagnoses that comes into a neurologist's mind, ranging from metabolic to degenerative causes. The metabolic causes being as hepatic encephalopathy or porphyria, infectious causes such as viral encephalitis, HSV, Japanese encephalitis, West Nile virus encephalitis, subacute sclerosing panencephalitis, a complication of measles, rabies virus encephalitis, neurosyphilis, retrovirus-associated neurocognitive disorders, and leptospiral diseases, if they are in conjunction with hepatorenal impairment. Then there are some, this patient had received drugs, typically antipsychotic drugs from outside, as he was diagnosed with mania. So we had also kept a possibility of drug-induced encephalopathy in mind, and our main differentials for this were serotonin syndrome or neuroleptic malignant syndrome. Amongst the vascular causes, there is a possibility of primary or secondary CNS vasculitis, CADASIL. Amongst the toxins that can present like this, it is alcohol, mercury, and lead. Alcohol has two ways of presentation with neuropsychiatric symptoms. One is because of Marchafava-Bignami disease, and other is because of Wernicke-Korsakoff psychosis. Amongst the nutritional deficiency, vitamin B12 deficiency is also known to present in such a manner. And amongst the other causes of encephalitis, one of the major causes are autoimmune encephalitis and paraneoplastic encephalitis. Amongst the autoimmune encephalitis with antibodies directed to the cell surface antigens, anti-NMDA antibodies, anti-IGLON5, anti-AMPA, anti-LGI, and anti-mGluR5 are well known associated with such a presentation. And particularly in this patient, because there were sleep disturbances along with respiratory disturbances and some walking difficulty and tendency to falls with a rapidly progressive neurocognitive decline, we had kept the possibility of anti-IGLON5 and anti-LGI very high in the order. Amongst the paraneoplastic encephalitis causes in which the antibodies are directed against the intracellular antigens, some of the very well-known presenting features which present like this are anti-U, anti-MA2 antibodies, anti-CV2, anti-CRMP5, and anti-ampifysin antibodies. Amongst the endocrine causes of such a presentation, Hashimoto's encephalitis, or now known as steroid-responsive encephalopathy with autoimmune thyroiditis, are also well-known causes. And last but not the least, degenerative diseases like Creutzfeldt-Jakob disease are very crucial to the diagnosis of such patients. So, out of such a long list, I had to cut short some, because there was no prior vascular risk factor like diabetes or hypertension, and there were no features suggestive of systemic vasculitis, no history of migraines or migraine and headache. We had kept the possibility of CADASIL quite down. No history of substance abuse or occupational exposure. We had kept the toxins also as a lower down possibility. And because there was no alcohol intake or any risk factor to develop thiamine deficiency, Wernicke-Korsakoff psychosis was also ruled out from our differentials. Then we were left with rest of the causes to be evaluated. So, how do we get another clue? For that, we reviewed the records that we already had from 4 different hospitals. This was a patient that had roamed about to almost 9 doctors, 4 different specialties, including ophthalmologists, psychiatrists, neurologists, neurosurgeons, across 2 different states of India, with a disease duration of almost 2.5 months, and yet the patient was not diagnosed. So this had left me completely perplexed, and I was sure that I would get some clues from the hospital records available. So we dived into it, and in that we could see that the CBC was normal, RFT and electrolytes were normal, CRP was elevated, and there was mild elevation of liver function test with SGPT and SGOT being elevated up to 2 times the upper limit of normal. Serum creatine kinase was available from 2 hospitals, and one of them was elevated to 3 times the upper limit of normal. Amongst the workup of thyroid profile, TSH was available and it was normal. Serum ammonia as tested by 2 hospitals was normal. Total proteins, albumin, to look for the markers of the chronic liver disease, we did look for the total proteins and albumin, and that was normal. INR was also normal. The viral workup consisted of HIV, HbA/CG, and HCV tested by ELISA. It was negative. One doctor from the previous hospital had suspected him of having some lithium toxicity because he had received lithium for almost 12 to 13 days at a stretch. And so he had measured lithium levels, and that were also within normal limit. There was almost no evidence of sepsis, as patient was afebrile during the entire course of illness, except for one episode of fever recorded during one hospital stay, and that too was just 102 degree, and thereafter the fever did not recur, and that was also checked by procalcitonin, which was negative. An anti-NMDA antibody was sent by one of the laboratories, but we were not able to trace it because the patient had taken discharge from multiple hospitals when he presented to us. TSF routine micro was available almost 2 months into the illness from hospital C, which suggested that proteins were normal, sugar was normal, and there were 4 cells with 100% lymphocytes. CSF ADA was negative, and HSV PCR only was available from the CSF, which was negative. Are you able to see the entire slide?
No, there is still a pop-up which is there. If you can, remove that. A part of the screen is hidden by the pop-up.
Ma'am, do one thing that you unshare the slide and then again share the slide.
Okay, fine.
Now again share the slide.
The issue has resolved or not? No.
No, still it's there. There must be some cross on the right hand side, ma'am. Can you close that?
I'm sharing it again. I hope it resolves for this time.
Yeah, now can you go for the full screen?
Yeah.
Now it's low.
Now it's visible. So I'm really sorry for this, and let us move ahead with the further investigations that were available.
Sanshu, sorry to disturb you.
Yes,
Can
sir.
you go to the previous slide, because the cell
Yes,
count of the
sir. Yes, sir.
CSF that you mentioned,
Yes, sir.
how much cells or sugar was 78 and cells were 4? Okay.
Yes,
Fine.
sir. Cells were
Oh.
4, protein was normal, and sugar was 78 with a corresponding blood sugar of 110.
All right. So nice. Thank you. Please go ahead.
So, as the patient was in hurry to move from one hospital to other hospital, he had incomplete records with him. But in his phone, I could get some clue. He opened up a few MRI scans, and in that I was able to see T1, T2, and flare sequences, which showed T2 and flare hyperintensities in the region of caudate and the putaminal region. And the other T1 going ahead, the T1 in the corresponding areas was hypointense. Then we got to see some EEG pictures with that patient. This EEG was suggestive of, from whatever the few pages that were available, this EEG had slowing in the theta range, but no other abnormal discharges, interictal discharges were noted. So the final differential diagnosis in this case was narrowed to drug-induced encephalopathy. In that, serotonin syndrome more than neuroleptic malignant syndrome. I'll tell you why. Acute viral encephalitis, autoimmune or paraneoplastic encephalitis, hepatic encephalopathy, and CJD. However, now we had kept hepatic encephalopathy as very lower down in the list because there were no markers of chronic liver disease such as hypoalbuminemia or coagulopathy. And one very strong point in the favor of hepatic encephalopathy is presence of T1 hyperintensities in caudate, putamen, and the basal ganglia regions because of manganese deposition. And this was a case in which I did not see any T1 hyperintensities. Although there were some clues which would make me still keep hepatic encephalopathy as a possible diagnosis, because patient was constipated since a long time. It had been almost 10 days. That patient did not pass any stools, and there was also a past history of jaundice before 6 months. So we went ahead with further investigations. At my institute, I repeated his CSF routine micro. To my surprise, it was different than the last time. Proteins were 39, glucose was 78, with 120 cells now, and all with a lymphocytic pleocytosis. We were not sure about the technical considerations taken into the practice while sending serum ammonia that was available from outside hospitals, because serum arterial ammonia has to be sent in the fresh sample with a cold ice pack, and it has to be processed immediately by lab. So, keeping a possibility of hepatic encephalopathy in mind, I did send serum arterial ammonia in my presence, and we planned him for a bedside EEG. Meanwhile, with the other differential diagnosis of neurosyphilis and acute viral encephalitis, as well as SSP and autoimmune paraneoplastic encephalitis syndrome, we did send some other reports consisting of CSF viral panel, CSF VDRL, CSF for measles antibody, CSF for malignant cytology, CSF autoimmune and paraneoplastic panel with IGLON 5 and Kelch-like L1 protein antibody. Along with this, for malignancy screening and to look for the status of liver and portal vein and spleen, we did check his ultrasound abdomen. And we underwent a chest X-ray which was completely normal with no evidence of any hilar lymphadenopathy. Now coming to the point of if it was a drug-induced encephalopathy, then what was it? Was it a serotonin syndrome or was it a neuroleptic malignant syndrome? This is one of the most confusing things in neurology that I used to find from my residency days, because altered sensorium, antipsychotic drug usage, rigidity with abnormal movements, autonomic instability, and raised serum creatine kinase are common to both these disorders. We had also repeated his CK at our institute, and we had found it to be significantly elevated at the level of 1800. Thanks to my PG guide, Professor Dr. Vimal Kumar Paliwal sir, who had made this confusion very clear for me in the initial days of my residency. So here for the residents, I repeat this, that in such a case, if the deep tendon reflexes are depressed, then it's a case of neuroleptic malignant syndrome most likely. Whereas if the deep tendon reflexes are exaggerated with myoclonus, then it more likely favors to the possibility of serotonin syndrome. So with these possibilities in our mind, on the day one of his admission at KGMU, we had made some major revisions in his treatment. All his antipsychotic drugs were stopped, including thioridazine, which was started by the latest hospital before us in the management. We maintained adequate hydration. We continued the rifaximin and lactulose with a suspicion of hepatic encephalopathy in mind, and lactulose enema was added to the regimen. Along with this, as first line of management of serotonin syndrome, we started him on lorazepam 4 mg IV every 1 to 2 hourly. And with the possibility of viral encephalitis in mind, injection acyclovir was started and ceftriaxone and vancomycin were continued. Levetiracetam, started by previous hospital, was changed by brivaracetam by us, keeping a possibility of levetiracetam-induced agitation in mind. And with the suspicion of autoimmune and paraneoplastic encephalitis as potential reversible causes, we also empirically started him on injection IVIG with a dose of 2 gram per kg of body weight over 5 days, as he had already received MPS pulse therapy at 2 different hospitals with total duration more than 9 days now, showing no response. We had stopped MPS and started him on IVIG treatment. On day 2 of his treatment at KGMU, what was the change in the scene? There was a significant improvement in his autonomic instability. Prior to giving IVIG, he required 2 doses of cilnidipine and 2 doses of carvedilol per day, and in spite of that, his blood pressure used to fluctuate from 110 by 70 of systolic to around 190 by 105 millimeters of mercury on the higher side, and his heart rate used to remain in the range of 125 to 135. Just 1 day of IVIG therapy, and there was a marked improvement in his autonomic instability such that all his blood pressure readings were now below 130 by 80, and his heart rate was between 70 to 80, and both the drugs were now stopped. He was maintaining normal temperature as before, and there was slight improvement in his sensorium such that he had partially started following commands and had become responsive to naming. But the problems of myoclonus, rigidity, and hyperreflexia had remained almost the same. So, with the possibility of partially responding serotonin syndrome in my mind, we had started him on cyproheptadine. Cyproheptadine, a serotonergic antagonist, was given at a starting dose of 12 gram loading, followed by 2 gram every 2 hourly. And by the end of this day 2 of treatment, I had traced a report of patient which was sent by Hospital C. Further in my slides, I am going to discuss with you that report. By the end of day 3, we had also received the reports from our institute, which consisted of serum arterial ammonia, which had come out to be 54. CSF viral panel was negative, which was checked for Japanese encephalitis virus, West Nile virus, cytomegalovirus. CSF VDRL was negative. CSF for measles antibody, both IgM and IgG had turned out to be negative, and measles PCR was also run in the sample, that was also negative. CSF for malignant cytology was negative. CSF autoimmune and paraneoplastic panel along with anti-Igelon 5 and Kelch-like L1 protein antibody also came out to be negative. This was sheer disappointment as it was ruling out all the possible treatable causes for us. We had also done ultrasound abdomen, which was normal. Then with suspicion of a possibility of non-convulsive status epilepticus or CGD in mind, we repeated his bedside EEG. And this is the bedside EEG that you can see. In this, there were sharp slow wave complexes occurring at short interval and they were quasi-periodic, which was followed by slowing in the delta and theta range. But these sharp discharges were not time-locked with the myoclonus, and these sharp slow wave discharges were present only during a minimum period of the study. From the entire study duration of 30 minutes, such sharp slow wave discharges were present to less than 1 to 2 minutes. And majority of the epochs consisted of slowing in the theta range consisting of around 4 to 5 Hertz background. And the sleep architecture was completely destroyed. We could not see any sleep markers in this patient. So on day 4, after seeing this EEG, we had a very high likelihood of Creutzfeldt-Jakob disease in our mind. And as it is, the patient was not responding and its sensorium had deteriorated to E2, V2, M4 status. We had stopped his cyproheptadine. By this time, he had received cyproheptadine for 36 hours with no improvement. His rigidity persisted, but now all his DTRs were absent. IVIG, as decided, was continued for 2 more days, even though the autoimmune panel was negative. On day 5, patient had shock and was put on inotropic support along with mechanical ventilation. And then we arranged for his MRI films from the previous institute. And we observed that there were T2 and flare hyperintensity in the caudate region, in the putaminal region, and some part of the medial thalamus, though it is very faint, and corresponding region in T1 are hypointense as discussed before. And there was a clue in the DWI weighted images of this patient. In this DWI images, we can see a significant diffusion restriction involving the caudate, putamen, medialmost part of the thalamus, and the medial frontal cortices and occipital cortices on both the sides. Along with this, the temporal folds and basifrontal region and occipitotemporal connections were also showing diffusion restriction. Along with this, we had also seen diffusion restriction in the posterior most part of the parietal lobe. So now I'm going to reveal the report that I knew on day 2 of treating this patient. This report was available from Amrita Institute of Medical Sciences and Research Center, and this report was none other than CSF 1433 sent by a hospital at Surat, sent by Dr. Mehul Desai sir from Kiran Hospital. And this report showed CSF 1433 to be positive. This was a quantitative assay, and it showed that the CSF 1433 levels were 99,277 AU per ml. If the reference range given as greater than 50,000 to be probable diagnosis of CJD, with greater than 1 lakh having very high risk of CJD. Now, you would think that if I already knew this report on day 2 of treatment, Then why did I plan this patient for autoimmune panel and paraneoplastic panel? The reason is there were some discrepancies in his presentation that I had observed from literature. When I reviewed about the clinical manifestations of CJD, I had observed that myoclonus is present in 90% of patients. Cerebellar features prevalence ranges from 20 to 40%. Corticospinal tract findings prevalence ranges from 40 to 80%. And neuropsychiatric features are almost universal in CJD. But the extrapyramidal features are relatively rare as compared to other manifestations. And our patient had florid extrapyramidal features in the form of axial and appendicular red pipe rigidity and whole body in an akinetic mute state along with rigid flexion. That's why this was one pointer. Plus, it is said that if in the CSF of a CJD patient, if we observe lymphocytic pleocytosis, then we should be careful for evaluation of diagnosis other than CJD, and those diagnoses include viral encephalitis as well as autoimmune or paraneoplastic encephalitis. Akinetic mute state is an end stage of CJD. Younger patients are reported to have aggressive neuropsychiatric features with more prolonged clinical course. Younger in terms of CJD means younger than the average age of CJD, that is 62 years of age. And if there is early cranial nerve involvement, it indicates an alternative diagnosis. So we did another extensive literature review about CJD and CSF 1433. So I studied about the utility of the CSF routine microscopy in CJD. In CJD, the CSF contains no cells and usually has a normal glucose level. An elevated CSF protein occurs in approximately 40% patients of CJD. An elevated WBC count, presence of oligoclonal bands, and IgG index should prompt other diagnostic considerations such as autoimmune encephalitis. Then I looked onto what is the sensitivity and specificity of all tests that are used for the diagnosis of CJD. When I looked at the sensitivity and specificity of MRI, I found that MRI was 83 to 94% sensitivity, had sensitivity of 83 to 94%, and in that too, DWI MRI was more sensitive than FLAIR. As per the stages of CJD, the MRI manifestations vary. In the early stages of CJD, there is DWI restriction. In the intermediate stages of CJD, along with DWI restriction, we observe FLAIR abnormalities in caudate and putamen. And in the later stages of CJD, all we observe is hydrocephalus and brain volume atrophy. If it's a variant CJD, then apart from these hyperintensity, we see the double hockey stick sign concerning the pulvinar of the thalamus. Now, when I reviewed about the sensitivity and specificity of EEG in CJD, I found that EEG was 65% sensitive, and specificity of EEG for the diagnosis of CJD was very high, that's 90%. Now, coming to CSF 1433, Amrita Institute of Kochi in its report mentions that the sensitivity of CSF 1433 for diagnosis of CJD ranges from 90 to 95%, but its specificity is low. The specificity ranges anywhere between 40% to 100%, with false positive CSF 1433 reported in rabies virus encephalitis, Alzheimer's dementia, acute viral encephalitis, autoimmune encephalitis, and this was all the more a reason for me to be evaluating this patient for any other alternative cause of presentation other than CJD. And as my PG teacher, when I entered into the residency, the first thing that Professor Dr. Sanjeev Jha said to me is that the only job of a neurologist is to differentiate treatable from a non-treatable cause. And I followed that during my entire residency days. And we try to look in for all treatable causes as far as possible. Another armor in the diagnostics chain of CJD is CSF S100 neuron-specific enolase thymosin beta 4. Recently, studies have come up for the evaluation of CSF tau in CJD. If the CSF tau levels are greater than 1150 picogram per ml, then they are highly suggestive of CJD because its sensitivity and specificity is even higher than CSF 1433. Another very specific and perhaps the most specific test available right now for CJD diagnosis, apart from histopathology, is CSF RT-Quick analysis and nasal RT-Quick analysis. RT-Quick stands for real-time quacking-induced conversion, which directly detects the prion proteins, and therefore their specificity is very high as compared to the CSF 1433. Concerning CSF tau levels, it has been observed that if CSF total by phosphorylated tau ratio is high, it is very, very specific for CJD. CSF tau can also be used as a survival marker in CJD. Now, I was always very intrigued by this name, CSF 1433. So I did a literature review on CSF 1433, and to my surprise, this protein has not been discovered recently, but it has been described in NEJM's article as old as 1996. And in that, it was found that there are two human proteins which are very closely resembling to the prions found in the sheep. And these are protein 130 and 131. And CSF and this 1433 is the name of the antibody that binds to the protein spots 130 and 131 by protein gel electrophoresis. And as shown in the lowest figure on the right side, we can see these two large protein spots that can be seen on protein electrophoresis by silver stain gels. And now the sensitivity of these assays is even more. Previously, they were detecting only 2 protein spots, but now they are able to detect almost 6 protein spots. There was also an evidence-based guideline published in Green Neurology in the year of 2012, and this guideline was published by American Academy of Neurology. This guideline suggested the CSF 1433 specificity to be on higher side with specificity of almost 80% and sensitivity of 90%. So I think we have a reason to believe CSF 1433 too. Now, I looked on the utility of EEG in CJD. A characteristic EEG pattern of CJD is observed in 67 to 95% of patients. Positive predictive value of EEG in CJD is 95% and negative predictive value is 45%, with false positivity in Alzheimer's and vascular dementia. The characteristic feature in sporadic CJD is that of positive sharp wave complexes. These positive sharp wave complexes can either be generalized or lateralized, and they are strictly periodic cerebral potentials, with majority of them having a duration of 100 to 600 milliseconds and an intercomplex interval of 500 to 2000 milliseconds. At least 5 repetitive intervals with a duration difference of less than 500 milliseconds are required to exclude a semi-periodic activity. And the differentiating point of EEG in CJD and EEG in case of measles is that these are short, in CJD it is short interval periodic discharges, whereas in SSP it's a long interval periodic discharges. CJD discharges are consisting of sharp slow wave complexes which can either be biphasic or triphasic in morphology, whereas the discharges in case of SSP are consisting of Radermakers complexes, and the discharges in case of CJD, they are of shorter duration, whereas the Radermakers complexes are of longer duration. The typical interval between the discharges is 1 second in CJD, and it is greater than 4 seconds in case of SSP. And one another differentiating point is that time locking with myoclonus is observed in SSP, whereas time locking with myoclonus is not observed in cases of CJD. Now, our patient did not have any positive sharp wave complexes reported from the EEG that was done in Gujarat. Why was it so? I was surprised. So I did a literature review on the factors which affect the positive sharp wave complexes in CJD. The positive sharp wave complex in CJD is on the type of prion disease. Positive sharp wave complexes are observed in sporadic CJD, but they are not observed in variant CJD. They are very rarely observed in cases of genetic CJD, but they are almost never observed in Gerstmann-Straussler-Schrinker disease and fatal familial insomnia. The appearance of positive sharp wave complexes also depends on disease duration, with these discharges not being present during the early onset of disease and towards the later part of disease. There is only 1 or 2 month interval in between in which these discharges can be caught on EEG. It also depends upon the molecular subtype of the CJD that the patient has. It depends on age too. One study had evaluated that for patients of CJD who were less than 50 years of age, the chances of getting positive sharp wave complexes on EEG was only 22%. Whereas if the patient's age is greater than 70 years, the chances of getting positive sharp wave complexes on EEG increases to almost 90%. And our patient was just 52 years old. That might be one of the reasons that we did not find it very early in the course of the disease. And other thing that influences the catching of positive sharp wave complexes on EEG is the drugs that the patient is on. When patient is on benzodiazepines or phenobarbiturates, then we have less chances of getting this disease into the EEG. And iatrogenic CJD almost never has positive sharp wave complexes. So before telling that it's a CJD, I had to double confirm the diagnosis of CJD. I looked into the current CDC criteria for the diagnosis of CJD, in which I found that the diagnosis of definitive diagnosis of CJD is done only by histopathological confirmation, but without histopathology, we can maximum diagnose it up to the level of probable sporadic CJD, which requires a neuropsychiatric disorder with a positive RT-QuIC test or progressive dementia and at least 2 of the 4 clinical features consisting of myoclonus, visual or cerebellar disturbance, pyramidal or extrapyramidal dysfunction, and supportive findings on 1 or more of the tests like EEG, MRI, and CSF. And routine investigation should not suggest any alternative diagnosis. So, as per this criteria, our patient fulfilled all the 4 clinical features, had a progressive dementia, and had all 3 supportive findings in favor of CJD. But still, as neurologists, we always strive to look for something that is treatable and something that can make a difference in the lives of our patients. So, but it is at the same time, it is very necessary to tell the truth of every condition to the patient and their relatives. So I had almost made up my mind for CJD, and I had called the patient's son in my room to explain the prognosis of CJD. I said there is no effective treatment for CJD and it's uniformly fatal. Death usually occurs within 1 year of symptom onset with the median disease duration of 6 months. And I was telling him about the treatment options, as he was very, very keen to listen on to any treatment option that is available to save the patient. So I did inform him about investigational therapies like flupertin, pentosine polyphosphate, doxycycline, quinacrine, and antisense oligonucleotides. And while I was almost closing this file, diagnosing it to be CJD, there entered the daughter-in-law of the patient in my room, and she came up with a Bollywood twist in the story. She told that recently she has received a phone call from her father-in-law's village saying that he was bitten by a mad dog a year back and had received for anti-rabies virus vaccine after that. I asked that initially I did ask you about the animal exposure. Why didn't you say? She said, our father never liked us to be bothered by his illnesses, so he never told us about it, and we get to know it today, when everyone in the village knows that our father is really, really sick. And then I was perplexed even more. Was it rabies that I was missing out, disguised in CJD? And I wanted to rectify this mistake of mine because rabies was something that I had not treated until now. And it was probably having some hope and some treatment to offer to this patient. So I was at the rescue of our microbiology department for rabies testing. And Dr. Suruchi ma'am in our microbiology department was very kind to immediately run the rabies samples both in saliva and CSF by PCR testing, but it came out to be negative. Rabies IgG was also tested at our lab and it came out to be positive. As immunoglobulin positivity is there, we suppose that patient has immunity against rabies, and rabies could not have been the cause of this hyperagitated delirium with neuropsychiatric decline in this patient. The current situation of this patient is such that he is on a CPAP mode of ventilation with FiO2 of 21% and maintains a tidal volume of 450 ml at pressure of 15 centimeters of water. His vitals are running stable and his inotropes have been stopped. Sensorium is almost the same, with the CNS status being at E4, VT, M4 status, pupils bilateral normal size normally reacting to light, and plantar's bilateral flexors. All his reflexes are yet diminished. He still has myoclonus, which is inducible by deep painful stimulus, but not reproducible or sensitive to visual or auditory stimuli. And here I'll show you the current video of this patient. There we observe the myoclonus on touching the hand of the patient. I mean, not on light touch, but when I used to press his soft tissues, then he used to have myoclonus after that, with a little lag interval of around 1 to 2 seconds. And this myoclonus was not reproducible on light touch or on auditory stimulus. Now that we have diagnosed this patient as sporadic CJD, a probable sporadic CJD as per the current CDC criteria, there are some crossroads ahead in the management, particularly navigating its ethical concerns. The first and foremost point that I need to put is that, do I need to really confirm the diagnosis of CJD? If yes, then how do I confirm it? Because CSF RT-Quick analysis is still not available in India and the patient's relatives denied for brain biopsy. The primary reason being that they were explained that if we do brain biopsy of a suspected CJD patient, then the last rituals cannot be done in a normal way and the embalming of the body cannot be done in a normal way. They wanted to follow all the rituals concerned with the burial, so they denied for biopsy straight away. If this patient has definitive CJD, then what is the cause of CJD in this patient? This left me perplexed. He did have a history of surgery, but that surgery was not a neurosurgery. That surgery was a laparoscopic inguinal hernia repair. That too done 15 years back. Could that have caused CJD in this patient? Theoretically, yes. The incubation period of CJD ranges from around 30 days to almost 42 years. And there is a probability that he might have caught this infection through the surgery that was done. Now, if it is a definitive CJD, especially a young onset CJD at the age of 52 years, then do I need to do genetic analysis for this? Ideally, yes. If CJD develops before the age of 55 years, genetic analysis is warranted. But I doubt if we are ethical in doing genetic analysis for a disease as fatal and as debilitating as CJD. What would be the psychological consequences to those families who are diagnosed and living in constant threat of them being affected by a fatal disease anytime during their life course? And even if we do a genetic analysis, do we have anything at the current moment to prevent the disease from progressing? Now, there was one other concern raised by our professor of critical care medicine department, that what would he do of the laryngoscope that was used for his intubation, and what to do of the ventilator. So this is a big concern considering CJD in mind. And this is one patient which has already roamed about in 5 hospitals until now. And I doubt if any hospital had followed the proper sterilization measures required to decontaminate prions. Other question is that the relatives want me to put my best foot forward in the treatment. They do not want me to do anything lesser than the best for their patient. Now, knowing the prognosis of the condition and the limited research with poor evidence available, how far should I go for the treatment of this patient? I wonder if there is any armor still unused in the battle. And I am perplexed that we have now been knowing CJD for almost 40 years, and yet we do not have enough information on CJD. I wondered, why is it so? This is because CJD is very, very rare, with an estimated incidence of less than 1 per 10 lakh of a population. And the disease is quite heterogeneous in its prevalence, depending upon the ethnicity and the socio-cultural practices. And that's why we cannot have much research on a disease like CJD. Plus, there are other concerns with the definitive diagnosis of CJD, the potential limitation of doing brain biopsy and limiting the limited resources available in our country for biopsy of such patients. Now, coming to the answer to what our CCM department had raised, coming to the decontamination of such prion proteins, it is very essential for us to keep the instruments moist before sterilization, because if the instruments dry off, then it becomes even more difficult to eradicate prions from those instruments. And these are resistant to natural autoclaving temperatures. Therefore, we need to autoclave them at high temperature. Autoclaving of prions is done by pre-vacuum sterilizer or by gravity displacement sterilizer. In a pre-vacuum sterilizer, it can be done in a short time of 18 minutes at 134 degrees Celsius, and in a gravity displacement sterilizer, it has to be done for a prolonged time of 1 hour at 132 degrees Celsius. Second thing is chemical treatment. We need to soak all the instruments used in this patient in 1 NaOH for 1 hour. Then we need to rinse them and then autoclave by heating at 121 degrees Celsius for 30 minutes in a gravity displacement sterilizer. Ideally, all the instruments that have been used on CJD patients, especially the tissues which have high infectivity like eyes, brain and the spinal cord, they need to be incinerated. But how should we tell our biomedical waste management department to do it? Ideally, there should be a leak-proof container and there should be a biohazard symbol on it, sent and conveyed to the biomedical waste department to decontaminate it in the way that I have told. If it is a low infectivity tissue like liver or kidneys or skin or lungs, then we need not follow such a stringent measure. But if we are not able to sterilize any instrument used in high infectivity tissues, then it is advised to discard the instruments. Second concern was that my junior said, "Ma'am, you saw the patient without gloves. Now you will have CJD." So I reviewed about this, and CJD does not spread from contact on an intact skin membrane or mucous membrane, but yes, contact of conjunctival secretions with a non-intact or breached mucous membrane can cause CJD, and therefore it is recommended that all standard universal precautions are followed while seeing a CJD patient. As far as ventilators are concerned, there is no aerosol spread reported till date for CJD, and therefore ventilator sterilization is not yet recommended. However, it should be known that all these decontamination procedures told for prion are not very robust, as all these studies come from in vitro studies and not from human studies. So this entire story reminds me of Professor Dr. Fiona Costello ma'am's analogy. She had once said, if it appears like a duck, if it walks like a duck, and if it quacks like a duck, then it has to be a duck. So this was a case that started at CJD, ended at CJD. So I was lost in the labyrinth of my own mind, and this was the neurological odyssey of altered sensorium. That entire department of KGME neurology was involved in management for the last 3 weeks. I am indebted to my mentors in neurology for teaching and having patience with me. And I'm especially indebted to Professor Sanjeev Jasar to teach me that only job of a neurologist is to differentiate treatable from non-treatable. And all clinical acumen that I owe is to my respected professors, Professor Dr. Vimal Kumar Paliwal sir, Dr. Arvind Sharma sir, and respected Professor Dr. Jayanti Kalita ma'am. I wish to acknowledge my entire KGMU's neurology department, who were very patient, kind, helped me whole throughout the management of patient, and as well as making this presentation, and were always ready to help. I am indebted to Professor Dr. Sudhiran Kanot sir and his team, who were immensely helpful whole throughout testing. And I am grateful to Dr. Suruchi madam from our microbiology department, who ran a rabies PCR at very short notice. We are also grateful to the Department of Critical Care Medicine at KGMU, consisting of Dr. Avinash sir, Dr. Shrivas, and Dr. Shraddhanjali. Last but not the least, it will be very, very incomplete if I don't thank these patients' relatives who have been very, very compliant of each and every investigation that I told, and each and every treatment that we have taken forward. And they have been really patient and have helping us at every step. We are really grateful to them. Now I shall request Dr. Hardeep Malhotra sir to share his experience on such patients.
Yeah. Good afternoon, good evening, everyone. So I'll try to keep it short because I think that we have had a very exhaustive session. Just there are a few things that are very important in terms of the take-home message, as Dr. Swanshu has already highlighted. So the most important thing is that if we dig deep into the history, we can realize that there might be a lot of things that are going together. So the most important take-home message from my side is that if you're finding pleocytosis, number two, if there are concerns with respect to the autonomic instability in CJD, always be skeptical. Now, this is something which is important because when we are looking at the prion disorders as such, and we have the diagnosis of CJD with us, three things are important, whether this is a plain sporadic variant, whether it is a variant CJD or a familial CJD. There comes a point when we might be stuck with respect to the autonomic instability and insomnia issues, which led her to consider the Eglon 5. Then there was another entrant in the form of a dog bite. When we come back to the prion disorders, we have the Justman-Strasser syndrome along with the fatal familial insomnia. For the resident especially, it is very important to understand with GSS, we do not get autonomic dysfunction, which is important, which is a very important component of fatal familial insomnia. This is a very important thing as a differentiating feature. And the other part is when you are getting such high titers of 1433, then the likelihood that we are dealing with the sporadic or the familial variant are extremely high. And this makes the likelihood of GSS and FFI far, far low in the differential diagnosis. One thing which has been alluded to very nicely by Dr. Shwanshu, that if you're looking at the periodic complexes, then the likelihood that they would be associated with the variant forms or the sporadic forms are high, and they are not directly associated with the other forms. This is one thing. And just one last thing, that when we are dealing with this thing, because we have had experiences with giving through the Ommaya reservoir interferons, giving patients pegylated interferons, then dealing the patients with the rituximab with mixed results, we have been having ethical concerns because of which we have not been able to go ahead with publications. But it is, nice to see that people are coming up with humanized antibody models, especially with respect to PRN100, which was evaluated at the University College of London and which is now published. But this is too small a data to recommend anything which is of this magnitude and severity with conviction. So still we do not have very good things at hand. Last but not the least, the the RT quick test. Maybe in future, if we could have any hands-on experience on that, would be really nice to be there in the diagnostic armamentarium. With this, I thank the presenters and would like shift the baton back to the organizers. Thank you so much. Will be if you want me to answer a couple of questions in the chat which were there. There's one thing which was interesting. Is there a specific site of cortical ribboning for different causes? We do not have a lot of differentiating features, but as a rule of thumb, it is usually said that if there is something which is showing an evolution in the frontal lobes and the parietal lobes, have deep nuclear involvement, then the likelihood of CJD is very high. When you try to differentiate this with the hypoglycemic disorders and hypoxic ischemic encephalopathies, then the calcarine cortex is one thing which is spared in CJD but is involved in these disorders. And the evolution is from the dorsal stream, ventral stream, especially from the parieto-occipital cortices towards the anterior cortices. This is the what is the kind of differentiation that we have. We have another question where it was written, how do prion relate with the tau accumulation? This is usually the downstream effect, not a primary effect. People have shown that if there is a template, then the chances of tau accumulation are more. But are they directly related? No, they are proteinopathies, but they are not directly related. Sir, over to you. Shah sir and Dr. Lakshmi, over to you, please.
Dr. Lakshmi, would you like to summarize? Thank you, Dr. Malhotra and team, and Dr. Shwanshu specifically for the elaborate presentation, a lot of take-home points and nice, eloquent discussion. Thank you very much. Dr. Lakshmi, you please add.
My hearty thanks to the entire KGMS team, sir, and Professor Malhotra. It was an excellent case. with a lot of take-home messages, and the presentation was so excellent. She has taken a lot of pains to go through every minor aspect. She has taken through the differentials of CJD and how the neuroleptic malignant syndrome and serotonin syndrome. In fact, I'm proud to say that my teacher, Professor AVS and Professor C. Velmurugendran, they have the criteria of C. Velmurugendran and the AVS CUV AVS criteria for neuroleptic malignant syndrome has been one of the it was published in the Practical Neurology in O.C. Biller, and long back, and when we were students, that was a criteria which was followed across the globe, and we are proud that a lot of work has been done by Professor A.V. Srinivasan on this. I want the postgraduates to know, because it's an original Indian work on NMS and serotonin syndrome. Both of them worked in the Institute of Mental Health, and they took all the cases of neuroleptic malignant syndrome, large series. In fact, the PhD work of Professor AVS was on NMS, neuroleptic malignant syndrome. So I'm thankful for the King George, the prestigious King George Lucknow Institute and Medical University. Thank you so much for a beautiful case. Thank you.
Thank you, sir.
Thank you, sir. And today we are incredibly grateful to all of you for joining us in this Secret of Neurology. We have successfully completed a 56th session of this insightful web series. And on behalf of Intas Pharmaceutical, I, Arun Chadha, Vice President of Intas Pharmaceutical, extend heartfelt gratitude to all our esteemed delegates for joining us on this momentous journey. A special thanks to you, sir, to our esteemed course director, Dr. Sudhir Shah, sir, as well as Dr. Lakshmi Narasimhan, sir, for designing such a fantastic web series on neurology. This program will be undoubtedly very valuable resource for all the DM and DME students. And we are incredibly grateful to the young neurologist, Dr. Saritesh Kumar Thakur, for sharing their insightful case presentation. And we are thankful to Swanshu ma'am for giving the detailed localization of this case and giving the insightful journey of this case also. And we are very thankful to Dr. Hardeep Singh Malhotra, sir, for giving insight of this case and providing the crucial learning points and summarizing and the proceeding of the unique presentation. Once again, a heartfelt thanks to all of you for your gracious presence, and it's been a pleasure being with all of you for the 56th session of Secret of Neurology. Once again, we will meet on 26th April for the next session of the Secret of Neurology. Until then, stay safe and take care. Thank you. Thank you very much. Thank you, sir. Thank you very much.
Thank you.
Thank you.
Thank you so much.
Thank you, sir.
Thank you
Thank you,
so
Dr.
much,
Steve.
sir. Thank you.
Thank you. Thank you very much.
Support.